For patients with myocardial infarction, the efficacy of beta-blocker treatment is well documented. However, trials mainly involved patients with large myocardial infarctions and left ventricular systolic dysfunction. And the trials predated advances like biomarker-based myocardial infarction diagnosis and treatment with percutaneous coronary interventions, antithrombotic agents, high-intensity statins, and renin-angiotensin-aldosterone system antagonists. A new trial evaluated the efficacy and safety of long-term beta-blocker therapy in patients with acute myocardial infarction and preserved ejection fraction. In this registry-based parallel group open-label trial, 5,020 patients, mostly from Sweden, with acute myocardial infarction who underwent early coronary angiography and had a left ventricular ejection fraction of 50% or greater, were randomly assigned to beta-blocker treatment or no beta-blocker treatment. The primary endpoint, the composite of death from any cause or new myocardial infarction, during a median follow-up of 3.5 years, occurred in 7.9% of the patients in the beta-blocker group, as compared with 8.3% of those in the no beta-blocker group, a difference that was not statistically significant. For secondary endpoints, including death from any cause, death from cardiovascular causes, myocardial infarction, hospitalization for atrial fibrillation, and hospitalization for heart failure, the treatment groups had no apparent differences. The risk of safety endpoints was also similar between groups. The authors conclude that for patients with acute myocardial infarction and preserved ejection fraction undergoing early coronary angiography, long-term treatment with beta-blockers did not reduce the composite risk of death or myocardial infarction. Full trial results are available at NEJM.org.